appears less frequently or with less intensity among females than among males? This is the question which I posed to frame up my selection of a rare disability for discussion with Class 522, and the first answer I came across was muscular dystrophy. The MD disorder is inherited with an X-linked recessive inheritance pattern. The gene is loaded onto the X chromosome. Since women have two X chromosomes, if one X chromosome has the defective gene, the second chromosome will have a working copy of the gene to compensate. In these cases, some women have much milder or no symptoms at all. Men have an X and a Y chromosome, and because they don't have another X to compensate for the defective gene, they will develop symptoms if they inherit the defective gene. There are 30 types of muscular dystrophy or dystrophinopathies according to the NORD site. The dystrophinopathies are a spectrum of muscle diseases, each caused by alterations in the Duchenne MD gene. The severe end of the spectrum is known as Duchenne MD, and the less severe end as Becker muscular dystrophy. NORD lists the rate of incidence for only the Duchenne and Becker types of muscular dystrophy. Duchenne muscular dystrophy occurs approximately 1 in 3,500 male births, and Becker's muscular dystrophy occurs approximately in 3 to 6 of every 100,000 male births. I also have a personal interest in muscular dystrophy because my father-in-law had a late onset form of limb-girdle muscular dystrophy. He was diagnosed in his 60s from a muscle sample test. Looking specifically at Duchenne MD and Becker MD, the onset and development are very similar, except that Duchenne MD is more aggressive, has an earlier and greater impact. Individuals with Duchenne MD lose mobility more quickly than those with Becker MD. Here is a layman's description of the genetic anomaly. Duchenne MD is directly associated with the short arm, P, of the X chromosome. The gene regulates the production of a protein called dystrophin, and that's where we get that long word, dystrophinopathies. Dystrophin is thought to play an important role in maintaining the structure of muscle cells. Duchenne is classified as a dystrophinopathy. Levels of dystrophin are examined through tissue sampling as part of a diagnosis. Duchenne MD is generally recognized between ages 3 and 6 and is characterized by weakness and atrophy of the muscles of the pelvic area, followed by involvement of the shoulder muscles. As the disease progresses, muscle weakness and atrophy spread to affect the trunk and forearms and gradually progress to involve additional muscles of the body. The disorder is progressive, and most affected individuals require a wheelchair by the teenage years. Serious life-threatening complications may develop, including disease of the heart muscle, cardiomyopathy, and breathing difficulties. Becker's MD patients often continue to walk independently into their late 20s to early 30s, not requiring mobility assistive technology until middle adulthood, while those with Duchenne MD may have lost mobility during the teen years. The most common topic relating to Becker's MD in journals and medical papers deals with Becker's patients receiving heart transplants and the attending prep and recovery issues with having heart transplant in an MD environment. The Becker's patients discussed in the situation of needing cardiac support or transplantation were teenaged. MD patients may live 50s and 60s years old and even longer if the cardiac and respiratory systems are maintained. Children with MD exhibit reduced muscle development. Muscle weakness occurs in the arms, neck, and other areas, but manifests first in the lower half of the body. Calf muscles initially enlarge as the body attempts to compensate for loss of muscle strength. The enlarged muscle tissue is eventually replaced by fat and connective tissue. Muscle contractures occur in the legs and heels, causing inability to use the muscles because of shortening of the muscle fibers and fibrosis of the connective tissue. From this strain, bones can be pulled into misformation. Skeletal deformities of the chest and other areas may result. Cardiomyopathy, damage to the heart, does not occur as commonly with Becker's as it does with Duchenne's. Cognitive problems may accompany the disorder, but they are not as inevitable and do not worsen as the disorder progresses. Because MD is an inherited disorder, genetic testing and careful observation of the family members are in order. We've kind of talked about the symptoms. We've talked about the signs. There are some clinical tests that were listed. The CPI may be tested. It may be higher than normal. An EMG shows that weakness is caused by destruction of muscle tissue, dystrophy, rather than by nerve damage, neuropathy. Muscle and biopsy and blood test confirms a diagnosis. As for treatment, there is no known treatment cure for MD. There are current new advances in gene therapy at several institutions, including the Columbus Children's Research Institute. These are in phase 2, which means they're not quite ready yet for administration to humans. So, traditional treatment is aimed at control of symptoms to support quality of life. Steroids may be prescribed to keep a patient walking for as long as possible. Activity is encouraged. Inactivity such as bed rest can worsen the muscle atrophy. Physical therapy may be helpful to maintain muscle strength. Orthopedic appliances such as braces and wheelchairs may improve mobility. There is a list of wonderful organizations here, and of course we're familiar with March of Dimes, which has a website, and the Muscular Dystrophy Association has a website. Thanks for listening to my little presentation on muscular dystrophy.